Welcome our panelists for expanding access to optimal cancer care. Jonathan Watkins, Dr. June Lee, Dr. Vijay Trisal, and Dr. Cheryl G.A. Graham-Mendola.
All right, good morning, everyone. How's everybody doing? Good. Enjoying the conference so far? Awesome. Well, it's about to get even greater. So my name is Jonathan Watkins. I have the proud privilege of serving as the president of City of Hope Atlanta, and I have the honor of moderating today's panel of distinguished guests to talk about how we truly expand access to optimal cancer care. But before hopping in, I'd like to let my panelists introduce themselves. I'll start with Dr. Lee.
Thank you so much. Thanks, Jonathan and Russ, for letting us participate and letting me participate. My name is June Lee. I'm the CEO of Emory Healthcare. I'm an interventional cardiologist by training. Being a plumber probably makes me least qualified to be in this panel, but I am an aspiring and actually an oncologist wannabe, so maybe that makes it hopefully appropriately so. And obviously, Emory Healthcare is an academic health system centered in Atlanta, and we have 11 campuses, and the centerpiece of which is really, from a cancer standpoint, the Cancer Service Line and Winship Cancer Center, which you've seen both headquartered at the Clifton campus as well as Midtown. And our mission is to really provide the highest quality care with the utmost compassion while innovating and educating. And we can talk about how that extends to really the cancer care and our obligation, as well as the need for the broad cancer care, which I know that we're going to be talking about. So thanks again for the opportunity, and I'll turn it over to Cheryl.
Hey, and welcome everyone, and thank you for the invitation to join my distinguished panelists today. I really appreciate it. I'm Cheryl Gabram. I'm the Chief Scientific Officer for Georgia Core. We're the Center for Oncology Research and Education. We're a nonprofit organization with the mission of advancing cancer research and clinical care through partnerships and innovations. So think of us as Switzerland. We work with all healthcare systems and different partners and practices throughout the state of Georgia with the goal of decreasing mortality rate from cancer for all Georgians, especially in underserved and minority communities. Now, the reason I'm so passionate about this is because I'm retired from Emory. 2.5 years ago, I took this position with Georgia Core, and my husband teases me. I lasted 2 weeks in retirement, and I was previously professor of surgery. I practiced 38 years. I practiced as a surgeon, and 10 years as the chief of Emory surgery at Grady. So I really understand in terms of improving access. A little more about Georgia Core, though. We were started back in March of 2003. It was Governor Roy Barnes' vision at that time to use tobacco settlement dollars to create cancer programs, the Regional Cancer Coalitions, Georgia Core, the Georgia Cancer Coalition. Our charge was to focus on clinical trials, though, because in the end, the best care is really given to patients on clinical trials. Why is that? Because not only do you receive standard, but you have the potential of receiving kind of cutting-edge therapies, and you're monitored very closely. Your cancer, nurse is going to call you up, make sure you show up for appointments, et cetera. So it's very important for us, and Georgia Core was given the charge to advance clinical trials, cancer clinical trials around the state. One last comment is that the whole premise, too, of our organization is that we want to keep Georgians in Georgia, okay? And I can personally attest to this, that it is important to be treated in your community. A month after I took the job of chief of surgery at Grady in 2011, I was diagnosed with breast cancer. And first, my first reaction was, I want anonymity. I'm gonna go up to Wisconsin and go see my friend who runs the breast center and just get my surgery and stay undercover. But in the end, I was lucky. I stayed in Atlanta, received my care in Atlanta, where I could be close to friends and family, and I think it helped my recovery. And after 8 weeks, went back to work and just hit the ground running, and it really helped. And so that's what we want to do. We want to keep Georgians in Georgia for that cutting-edge cancer care.
Thank you, Cheryl. Before I introduce myself, I just wanted to take a moment to thank Jonathan and Health Connect South I yesterday had one of the most amazing gatherings that I met people from all diverse groups. We sometimes get kind of tied into our own world and don't connect with people that are from different areas, understand that. I met some amazing data scientists. I met some amazing thinkers and folks who are venture capitalists, and how we can play together to be able to get to a goal where the care that we identify and the care that we structure gets to the right people. And as Russ had ordered us yesterday, we sat with a group of young students today, and we learned from them as well, coming from all diverse worlds. Like Cheryl, I am a surgeon as well, and I have the privilege of taking care of a hospital system by the name of City of Hope. Many of you who met me yesterday asked me, where is the city? They think of City of Hope as a city somewhere. City of Hope is a not-for-profit organization that focuses on research and cancer. And we have been taking care of people, making discoveries for the last 110 years. We started in the West and now are the only and the largest cancer system across the whole country. And in Georgia, we are in Newnan, and Jonathan has been leading us in that world. City of Hope started as a tubercular sanatorium 110 years back, taking care of people who did not have access to care. At that time, there really wasn't any treatment for tuberculosis, so it was all taking care of how do you help people to live with dignity and die with dignity. We opened 2 tents. One of them was for caregivers. One of them was for patients that came from all across the world to Los Angeles to die there. And many of them, with good care, actually started living better. And once tuberculosis stopped becoming a scourge, we moved on to other life-threatening diseases and based it on the plinth, on the cornerstone of research. So anybody here heard of insulin? Oh, lots of people heard of insulin. The technology that created human insulin, the technology that created synthetic insulin, was developed at City of Hope. And similar to that, many of the current cancer drugs that are based on technologies, monoclonal antibodies that are pretty much used in even non-cancer treatments like rheumatoid arthritis, like lupus or ulcerative colitis or Crohn's disease, that technology was developed at City of Hope. And many of you might have heard of treatments like CAR T cells, engineered T cells that are developed for treatment of both liquid tumors like leukemias or lymphomas and solid tumors now. That technology was started at City of Hope. You will hear a lot of these new drugs now that are used in the treatment of hematological malignancies. So City of Hope is the largest bone marrow transplant center in the country. And when you look at these new therapies of CAR T cell, you will hear about BiTEs and TRITEs and treatments that actually are treatments that are not cytotoxic, that are not used to kill cancer cells, but engineer your own cells to be able to treat cancers. So that all technology was developed at City of Hope. So in Georgia, we're in Newnan, and we're focused primarily on cancer. All these discoveries that I talked about, they are not just in City of Hope, but we are utilizing them. We have currently about 90 INDs, new therapies, first-in-human trials that start at City of Hope. I know that's a long-winded answer to who we are, but it's important to understand, especially when people ask me, what city is this City of Hope in?
Thank you, Dr. Trisal. Just a point of personal privilege. Each time I hear Dr. Trisal or Vijay tell that story and talk about City of Hope, I feel like I grow a little taller. And I want to kind of puff my chest out and dust my shoulder off a little bit. It's a pretty cool organization to be a part of, so thank you. Before we get into the discussion, I want to kind of frame it with some not-so-fun facts, unfortunately, guys. In the 2021 National Health Interview Survey, 1 in 11 adults reported delaying or not getting medical care due to cost, which has also led to a reduction in health insurance adoption overall. The Journal of Rural Health indicates that rural patients requiring radiation travel around 40.8 miles to receive care. Urban patients, in comparison, travel an average of just 15.4 miles. So you layer, for instance, that's 40.8 in this Atlanta traffic, that would certainly deter people from receiving the care they need. In Georgia, the breast cancer mortality rate of black women is 40% higher than white women, according to the American Cancer Society. Living as a person of color in the U.S. correlates with poor health outcomes and mortality rates overall. But there is some good news. In fact, there's plenty of good news, and I'm going to get an opportunity to hear some of that. The U.S. cancer mortality rate has declined 33% since 1991. Among women in their early 20s, there was a 65% drop in cervical cancer rates from 2012 to 2019 in the wake of the introduction of the HPV vaccine. There are an estimated 16.9 million cancer survivors in the U.S. today, and that number is expected to grow to over 22.1 million by 2030. New treatment, screening, education strategies, as well as a renewed and stronger focus on diversity, equity, and inclusion, which again we've heard about today, are helping close that gap and improve some of the quality and the outcomes that we're hearing about. So how do we create more good news? That's what we're kind of here to talk about and we're going to focus on. So my first question for the panelists, when you think about the realities of the current barriers to cancer care and our progress so far, what stands out for you? And I'll start with you, Dr. Lee.
Thanks so much, Jonathan. You've really laid out some of our most pressing challenges in terms of, as the title says, optimal cancer care, right? And people, even though I've been at Emory for a short time, those who are from Emory already know that I'm kind of fixated on the access as a primary, a critical component for any healthcare system. But if you think about the barriers to access for cancer care, you really nicely outlined it. Sometimes we think of access as simply, how can I get the first appointment? How close is it? Yes, there's a geographical component to barrier to access, but you also pointed out there's an economic component. And then there's a perceived economic component. That is, even if you have economic access, if you believe it's going to make you bankrupt, people will not seek it. There's a social component, an educational component in terms of understanding what's needed, and then very unfortunately, there's a racial component, as you noted, in terms of how healthcare is delivered in this country. We have to tackle all of it, and then for us as a quaternary center, an academic health system, and the only NCI-designated cancer center in this state, we actually have the obligation to provide what I call secondary access. That is, the primary access to cancer care may actually occur with your local oncologist, who may not be part of Emory Healthcare. But it's our obligation to provide access for those patients to the very advanced care, the only proton beam therapy center, and the very advanced, some of the cellular therapy that's available at Emory Healthcare that's not available in the other centers. So we have to make sure, no matter how competitive you think the healthcare environment is, that we collaborate with the other organizations to make sure that we provide those access. You know, we have to understand those individualized barriers and try to tackle them in a collaborative fashion that is in terms of, for example, some of the economic barriers and perceived economic barriers. I know that we collaborated with Cheryl's organization for advocacy in terms of education and policy so that the insurance companies are obligated to pay for some genetic testing for cancer markers. So there are things that we can do together to collaborate and provide access. And since you mentioned, make another point, which many of you saw, the recent loan report, which unfortunately noted that Atlanta was a very segregated place in terms of healthcare delivery. But the good news is some of the centers, actually two of the Atlanta's medical centers, Grady and our Midtown campus, were in the top 10 in terms of racial inclusion, and that's out of 3,000 hospitals. So I'm very proud that our system has 4 out of the 5 most racially inclusive campuses in the Atlanta metro region and 4 out of the 6 in Georgia. That is, if you don't have access, if you're not seen at the local medical center, or if you don't feel like you have access to that, it's impossible to really create health equity. So we have a lot of work to do. Collaboration, as you're pointing out here, is a critical component of making progress, and we have to hit those individual barriers as a team, as a multifaceted healthcare organization, and in partnership with government and local organizations. So I'll stop there.
I'm going to continue on the theme of access, and thank you for giving the high-level view, Dr. Lee, but I'm going to specifically concentrate on clinical trials, cancer clinical trials. So we know that less than 5% of adults participate in any clinical trial. However, and for pediatric patients, it's up at 80–90%. So already there is such a divergence there. Now, if you look at underrepresented communities, minority rural communities, they participate 5 times less than communities that have the access to these clinical trials. So we were motivated to kind of get the word out to how can we solve this problem. So last year, GASCO, the Georgia Society for Clinical Oncology, and Georgia Corps partnered, and we put it on a Disparities in Cancer Clinical Trials Summit. We brought leaders from the entire state together to talk about this problem and identify areas where we can really work on. And it was interesting because I had the opportunity to interview a patient to tell her story to the summit participants. Kimberly Michelle Smith is a 36-year-old breast cancer survivor, Black breast cancer survivor, who, when she was treated here in Atlanta, she was approached with a clinical trial, and she said, I was hesitant. I was hesitant about joining that trial, but then I remembered my mother told me, don't take anyone else's medications, meaning that if you have to know what drug, what concentration is going to work for you, it's important that you participate in clinical trials. And so she really delivered that important message. The other areas that we found were important were adjusting clinical trial design, improving the readability of consent forms that can be 20 pages plus long, decreasing implicit bias. We heard from Dr. Horry this morning that if you train minority and rural providers and put them in the communities will respond and adhere to care better. Well, until we get to that point, we do have a workforce issue. Why don't we look at implicit bias and teach folks that, make sure that you don't just discredit somebody from joining a clinical trial because you think they're not going to understand it or they're not going to buy onto it. And so take the time to explain that, and that's where navigation can also be very important.
Now let me paint the picture so we can understand the gravity of cancer itself as a big threat. 1 in 2 men will develop cancer in their lifetime. 1 in 3 women will develop cancer in their lifetime. And if you are in a place where you have a certain zip code, you have a 30 times better chance of survival. This is data from CDC that looked at different zip codes covering for all comorbidities. And the difference can be at multiple levels. Let me talk about one of those levels, is knowledge gaps. So in 1950, it took 50 years for scientific knowledge to double. So by 1950, let's say there was X amount of knowledge. In 2000, it was 2X. Today, knowledge doubling happens in 2 months. So basically, if I'm a lung cancer patient and I have a specific mutation, by the time that information gets to the right people who are treating them, that information has changed. So if living in one of those zip codes that doesn't have access to NCI designated comprehensive cancer center, doesn't have the knowledge of how to order genomic testing or to be able to do that. That is one part of it. The other part is the knowledge that Cheryl talked about. And then there's a third component of that, which is you do not look at these treatments from a perspective of what is going to be the future and how we quickly pivot. And unless you have this ability to take care of 80% of those cancers in the communities who would never, like Jonathan talked about, drive 100 miles, they would rather be taken care of or not taken care of by a doctor who doesn't have expertise in their cancer rather than drive 100 miles. So it becomes a responsibility. How do you take the care that we have to the people on the front lines? I'll tell you a couple, three things that we are doing on that front. The first one is the ability to not be self-serving. You will have 100 organizations come up here that we are the best organization for this type of cancer, come to us. But what happens to that patient that, number one, can't come to you, or is in a network that does not allow you to come to you, that has so narrow a network that you may have a specialist even next door, not even 5 miles away, but you can't go to that specialist. So with the partnership, actually, with Emory, what we have developed is a company called Access Hope. So what Access Hope does is directly partners with employers, major employers that are the top 500 employers in this country, and is able to give them access to the opinions of the specialists, no matter where they are. So we started this with City of Hope, and now we have foundational partners. Emory is a foundational partner. Dana-Farber is a foundational partner. Johns Hopkins is a foundational partner. Northwestern is a foundation partner. Fred Hutch, which is one of the pioneers of liquid tumor treatments in this country, is a foundational partner. So no matter where you are, what county you live in this country, you have the ability to get an opinion from an expert from any of these top cancer centers, and this number is broadly increasing. Taking treatments like that, being able to get to connect, to be a conduit between the specialists in this country to the patient who needs them, becomes an important part of our responsibility. The other part is when people are struggling with how do they manage their day, going to go get a mammogram, or we talk about getting screening for lung cancer, get screening for colon cancer, prostate cancer, or doing a whole body check that you don't have a melanoma, becomes very difficult for people to do that. What we did was create mobile units. So these units have a CAT scanner in them that can do this low-dose CT for people who are at high risk for lung cancer. In this country, the number of people that are eligible for lung cancer screening, of those folks, only about 10% of them are actually getting screening. So if you are thinking that a stage 1 lung cancer is the best cancer to treat, or a precancerous lesion, if you're not getting that patient to be able to get that CAT scan, you're not going to pick those lesions up. You only pick them up when they have symptoms and when they are metastatic, where now you are talking about pouring immense amount of resources and not being able to cure these patients. So it has to be a multi-pronged attack. Cheryl talked about clinical trials. Most of those novel drugs that are now being developed, by the time they would get to market, takes about 5 years. So what we did at City of Hope is take all these patients, we see about 200,000 unique patients every year, and make sure that we do a genomic testing on them. About 10% of cancers are driven by unique gene mutations, and only 1/3 of those patients are getting tested, so that not only would it impact them, but if they identified that I have a mutation in my germline, I would test my whole family so we'd know which members of the family are much more at risk, and we bring them to the fore, and either we prevent them by having prophylactic things to do, whether that is by treatment or by surgeries or by doing routine colonoscopies that are much more frequent. So it has to be a multi-pronged attack where we are not asking people to come to us, but taking the theater to them primarily, being able to break these barriers of institutions, that I am the best institution, but partnering with folks. And that's why when I talked about meeting with people that are from diverse industries, whether those are data scientists, or those are folks that are coming from ability to create access for people. I think we have to get together to break those barriers. It's like the feast and the famine. You have amazing amount of treatments available that have improved survival by 30% to 40%, but people can't access that. And those, I think we've done a better job at identifying them, but we need to be able to now act and break those barriers.
Thank you. So each of you kind of touched on access as a true challenge, access to clinical trials, access geographically, and access to the highest quality of care that's possible. Vijay, you somewhat touched on it, but I'd love to hear if there are other examples, and I'll start actually with you, Dr. Gabram, on this one, particularly given the unique role you all sit in. What are you and your organization doing to drive more access to cancer care and research? And can you kind of give us some examples of some things, again, because you all sit in a unique space?
So again, we started small back in 2005 to 2007. There's two names, Dr. Ruth O'Regan and Dr. Suresh Ramalingan, came to Georgia Core and wanted to open up their investigator-initiated clinical trials with Georgia Core. And that allowed us to create a network throughout the state to push their clinical trials to community practices. We developed the agreements back then because you can't just start these things up. You have to have formal agreements. And those agreements live on. So we do, over the years, we have developed an expanding network. Because of the successes of those two investigators early on and being able to accrue around the state, and by the way, on both their studies, 35% of individuals accrued were minority patients. And so that was a huge success, seen by a huge success by NCI. When Georgia was awarded an NCORE through Northside and St. Joseph's Canla, Georgia Core was asked to be a partner. So we're a partner of the NCI Community Oncology Research Program, which allows those sites around the state to open NCI trials. And so we oversee 6 of the community sites, Georgia Core does. There's currently over 100 providers, 43 sites, and last year they accrued nearly 400 patients throughout the state on these clinical trials. So that is just so exciting. But the story I want to tell is about the small cancer center, Perelman, down in Valdosta. Last year, about a year and a half ago, Natera reached out to us. They're a company who has the Signatera assay. And what they did is, it was an observational study, a simple study using the Signatera assay for colorectal cancer patients. So a patient who had colorectal surgery has their tumor resected. It gets sent to the lab at Natera. They developed this assay that is patient tumor specific, that one can detect if that tumor is coming back in the patient's body through a blood test instead of doing lots of CAT scans. So it's an observational study. We opened it with 7 partners throughout the state. Do you know that Valdosta put 50% of the patients on that study? They saw a bunch of colon cancer patients. They were able to put those patients on the study. And to me, even though it was an observational study, it allowed those patients down in South Georgia to have access to some technology that's FDA approved and other patients can benefit from. So that's what gets me excited about really pushing things out into the community.
Thank you. Dr. Lee?
Yeah, so as you were talking, I mean, you know, the theme is coming out here. It's interesting that cancer, even more than most other disease and specialties, that access to research and clinical trial is so critically important as what I would call, that's really, without that, you can't really deliver high quality cancer care. So that's why it's such a critical component. And you know, Cheryl really nicely outlined, you know, Suresh actually approaching. Suresh is our cancer center director, the NCI designated cancer center director, as part of his mission. And it's important for organizations like us to make sure that, once again, that the competitive nature of healthcare is put aside so that we're actually increasing access. And obviously, he felt very mission-driven and important that organizations like Cheryl's have the capacity to spread out access to clinical trial. And those organizations are critically important. And we have to hold hands so that we can maximize the access to clinical trials in different campuses so that they're not limited to the quaternary campuses or even large tertiary campuses, but wherever patients are, that they have that access ultimately to the latest and the best care that is available. And we have to hold hands in terms of how we advocate for such care when it comes to, Vijay nicely outlined, the mobile van, how it breaks down the barrier, and the organization breaks down those false economic barriers that sometimes comes because of the way our payer system works. Our job is to try to break those down so that we can maximize that access for the patients who need it. That's ultimately how we're going to have the most impact. And once again, from our standpoint, we want to make sure we ensure access for the most advanced care, for the clinical trials, and the latest in therapy, whether you happen to show up in a rural section or in the middle of Atlanta, and whether you're part of a small system or one of the very large systems. So that's critically important, and I know one of the themes is going to be collaboration, and hopefully you'll see that, because without the collaborative efforts, we're going to fragment things even more, make it even harder for our patients and those who need care to get the right care.
A couple of things I would like to add, Jonathan. One is that you have to work at different levels. You also have to work at the legislative level. So you might have heard we recently passed the Cancer Bill of Rights in California, where these narrow networks that won't allow their patients to seek a second opinion at cancer centers that could make a difference in the lives of 20 points. So when you look at the difference of survival between NCI-designated comprehensive cancer centers and a hospital that does not focus on a unique cancer, there's a 20-point difference in survival. And it becomes our responsibility to make sure that people are not, we can't say, hey, you don't have the insurance that we take. So the bill that we passed was unanimously passed in the California Senate that talked that in these specific cancers, not all cancers, these were cancers where both expertise is limited, small number of cancers, or on that phase where you have already exhausted a second, third line therapy, but there are these unique treatments that are available, not just in clinical trials, but even standard of care. So that Cancer Bill of Rights mandates patients who have these unique tumors like sarcomas. Many of you may not even have heard of, many doctors in their lifetime won't see a sarcoma, or treatments that have a difference in pathology. You'll be surprised that we treat people where we don't have the right pathology. That a pathology that is read on a prostate cancer has a 25% chance of having the wrong Gleason score, or a melanoma that has been read has a 20% chance of having the wrong level or the wrong stage if it is not read by an expert pathologist. So if you don't have the right diagnosis, you definitely are not going to get to the right treatment. So starting at getting the right pieces where the expertise helps, because tomorrow if I ask Dr. Lee that, hey, all those patients in Georgia should go to Emory, I don't think that is either possible or there is the expertise. But which ones of those that would make a big difference in their lives can get that part in their patient journey being opined on by those experts becomes critically important. So that is one, is to make sure that there are not legal compliance and insurance barriers. The second part is, even today when we talk about telehealth and the ability to opine 100, 200 miles later, farther away, there's a visceral reaction to cancer that is different than other diseases. Even cancers that are very curable, that had a 95, 97% chance of cure. The brick and mortar of being there, seeing the patient, touching the patient's hand, talking them through the treatment, being able to talk to them about end-of-life care, which becomes a critically important, or no care at all. When I talked about Access Hope, which is the model where employers can have access to these experts, we realized that in about 10%, only 10% of those patients that we saw that were already on a treatment, were they on the right treatment. In about 30% of those patients were getting treatment that was okay, but the dose could be modulated, or they could have a different treatment for toxicity monitoring or decreasing toxicity. In about 40% of those patients, it was absolutely the wrong treatment. And it was many a times over-treatment, where there is actually a 20 to 30% waste in the system. And if we could take that waste and apply it to the areas where are those patients or those communities where you don't have that access, you actually have a cost improvement in all of this. So it's not just adding cost to the system that is already burdened with increased costs. So legal legislature component, the ability to have brick and mortar sites where, if you talk about Noonan and its subsidiaries, it is not just asking everybody to come there, but taking it to them for those 80%, 90% treatments that can be done at the local site.
Thank you. Vijay, double-clicking on that, I'm going to direct this next one towards you. Because I know that in Duarte, you all went from a single site over a 10-year period to nearly 40 sites that City of Hope's located in, many of which are done through partnerships, collaboration, and relationships. Why does collaboration among healthcare organizations benefit patients, their families, and our communities? And what would you highlight as a partnership or a success story in that space for City of Hope?
I thought, Jonathan, you said you were going to answer me easy questions.
Yeah, I called an audible on you, buddy.
No, so as a cancer-only place, as a system that only takes care of cancer, we are not the place where you would go for cardiac care. You're not the place where you would go for care that is related to hypertension, or that is related to babies, or that's related to trauma. We don't take care of that. In fact, we partner with hospitals where if we have a patient that needs cardiac care, needs a cath, we would go to an Emory to say, hey, please take care of this. Vascular surgery, which is one of the complex treatments, or primary care, where making sure that somebody is getting a mammogram at the right point in the right place, or where we are doing immunizations in the right manner. So that partnership becomes critically important. The partnership of education is probably what is as, if not more important. So we have fellowship training programs that train surgical oncologists, medical oncologists, radiation oncologists, but our ability to get those trainees to be exceptional doctors depends on partnering with other organizations that do this so well, that have an educational system that is foundation of what they do, which is not what we do. So the expertise of what we do with the expertise of what others do makes it everybody a better system.
Thank you. Dr. Gabriel?
So again, everything I've said is collaboration is key. Unfortunately, in Georgia, there's enough cancer to go around for everyone, is what I always say, and that's sadly, but that's why we do have to develop all these linkages across the state. But the successful collaborative program that I would like to talk about is is the Breast Cancer Genetics Project, because it really is a nice story of collaboration, especially with the state as well. So way back in 2011, Dr. Roland Matthews, who's now the director of the Cancer Center down at Grady from Morehouse, and I saw this funding opportunity award for the CDC to fund a genetics project. And so we approached Nancy Paris, the CEO of Georgia Core, to apply for this. And we did receive the CDC 3-year funded grant that we would provide and teach a way for unaffected women who had a high risk for breast or ovarian cancer, but did not have cancer. As they entered the public health clinics, they could go online for screening to see if they were eligible for that germline testing that Dr. Trissell talked about. And so we were funded for 3 years, very exciting. After 3 years, the CDC no longer funded Georgia, but we reached out and had developed the relationships with the Department of Health. And so they continued the funding of this program through the BCC program, which is funded by CDC, interesting enough. And so to date, that program is still active. And we had a Rollins School of Public Health student study this program after 8 years. We reached 29,000 women. 50% of the individuals reached were in medically underserved areas in the state, and 63% self-identified as an ethnic or racial minority. So that's all very exciting. This program's up and running. But when we really looked at the numbers with our Rollins School of Public Health colleagues, we found that we could do better. And so we formed a collaboration with Yu Guan out of the Rollins School of Public Health. She submitted an R01 and was funded this past spring to study 6 clinics in Southwest Georgia who are up and running with this program, but randomizing 3 of them to an upstream intervention. So now text message the women. Instead of having them have to come to the clinic, can we text message them and inform them about this program, which can be all virtual. It can be they get their genetics counseling through Myriad, and then our genomics nurse talks to them about the results. But if they're low risk, the intervention group will have access to our website to still learn that you still need your screenings, and not only breast screening, but other screenings. So this program just launched. She received a perfect score on this grant. It was just amazing. And she actually received an additional 2 years. Now we have 7 years of funding to work with Southwest Georgia, something that we need to uptick this more throughout the entire state.
Thanks so much. That's so critically important. And I think one of the themes that we're seeing here again is that, look, I'm acutely aware that healthcare and health systems are in a highly competitive business. But the reality is that when it comes to cancer care, advanced cancer care, the organizations that we represent, they're assets to the region. And it is not only good to collaborate, it's really our obligation to collaborate to make sure that these assets work for everyone. Just like you said, the result, the outcome of your cancer should not depend on your zip code, and actually shouldn't depend on which health system you started, okay? You should really have access to the most advanced and the best cancer care for you. Do we have that system now? No. But is collaboration going to make it more likely to do so? Absolutely. And I think you've seen the rich collaboration between Cheryl's organization and Emory. Those are organizations, Cheryl's organization are the type of organizations we welcome because we know that that can make the cancer care better. And Jonathan, I think you'll say that when you and I first, or you met Ravi and myself, our approach wasn't so much, City of Hope, yet another competitor coming into the region, because we're aware of some of the special skills and different approaches that City of Hope brings. So our approach was more, okay, how can we partner? How can we synergize? And how can we energize the care of cancer for the whole region? That means that we'll probably shift some of our resources to efforts that we would have otherwise done differently if City of Hope had not come into the region. But as you pointed out, there are plenty of things that we can do that will raise the sea level, and that's what we want to do. And it is our obligation to do so for this region. And once again, it's really a fortunate asset to have these type of organizations, and as leaders, it's our obligation to try to make sure it's really working for as many people as possible.
There's another component, Dr. Lee, you'll speak to it better than I can, is this collaboration of data. There is so many gems in that data that understand what treatment works, what treatment costs less, what treatment has better outcomes. And in this rush and in this plethora or gazillion pieces of information, that collaboration of we have this unique patient, unique mutation, and this is the treatment that works better than this treatment, that collaboration becomes critically important between systems, between non-oncology, non-healthcare systems, and other industries.
I'm glad you mentioned that, right? Because of the competitive nature, sometimes it becomes like, for those of you who are older in the audience, between Betamax and VHS type of an issue, or Microsoft versus Apple type of an issue. But that only weakens the whole field, because given the power of the data management, machine learning, if we had access to the entirety of the data, that knowledge explosion will be even accelerated even more, And then it's our obligation, right? I mean, if I had cancer, if I have prostate cancer, I want the best therapy that was determined by the entirety of the population, not by 20 people who were seen in one system and so it's type of anecdotal report. So that collaboration is absolutely critical for all of us.
Thank you. I recognize that we're standing between you and lunch, and I know my chief of staff's stomach is going to start to growl pretty loudly if I don't hurry. So I will ask each of you just to provide us with one takeaway about expanding access that you'd like everyone to leave Health Connect South with. Start with you, Dr. Lee.
Okay, well, thanks so much. I mean, I think that it's obvious what the theme here is. We can't think of access as a single system access, and we have to really think about access as a region for the whole population, for the entirety of the population. And that will require a different type of collaboration than usually occurs within the healthcare system in this country. Unfortunately, you know, my view is that the American healthcare system has some of absolutely the best components in the world. That's why people come from all over the world to train here and learn about it. It also has some of the most challenging and I would argue dysfunctional components of a healthcare delivery system that's not seen anywhere else in the world. So our job and our obligation, especially for care for cancer, which is so complex, and it is the #2 killer, and heart disease remains #1 in this country, and we can talk about that for hours, but you would starve then. But it's really our obligation to make sure we try to break down those barriers where we can and try to increase the collaboration so that it really does become a cancer treatment system, not just a single center.
Well, if we're going to reach President Biden's moonshot goal of decreasing cancer mortality by 50% by 2047, I mean, it can get a little overwhelming when you think of kind of the big picture. But there are simple solutions, and one of them you heard me mention before. I'm a big believer in navigation. I really think navigating patients can make a difference. We see this, and we have another CDC award down in Southwest Georgia to increase colorectal screening in 4 FQHCs, 18 clinics, and we partner with Horizons, which is a regional cancer coalition, and with their navigation, the individuals who are navigated, the fit rate return is 75 to 80%. If the fit's positive, navigating to colonoscopy and being properly prepped is about 95%. So it does work. And I also found it working in my practice when I was at Grady, and Otis Brawley started the Navigators out of the Avon Breast Foundation. And they were women who were of the community who were diagnosed and had survived breast cancer. And they would come with us as we talked to the patients. And they encourage compliance, enrolling on clinical trials, because, again, they could relate to the community that they were talking with.
No, thank you, Cheryl. You mentioned a couple of stories, which is what I want to get back to. We talked about a lot of numbers. We talked about mortality, cancer patients, and when somebody gets cancer, it's not just that individual. It's the whole family impacted, the community is impacted, the job is impacted. And whenever we talk about these numbers, we should really look at it from that perspective of what happens to the individual. It's surprising when I, as the chief medical officer, talk to medical directors where, hey, this patient should come to CDFO because this is the benefit. And there's a lot of debate back and forth because it's economics and access and what's called adverse selection. But when that medical director has a patient or somebody that they know or a relative that has cancer, they know where the best treatment is. And it becomes personal. I think all these stories of cancer are personal stories. And whenever you think of this, think of that person that is in that family, in that job. And when we look at that, all these barriers will candidly automatically disappear and we will get to the right treatment, right place, right time.
Awesome. Let's give the panel a round of applause, please. Thank you all so much. I hope you enjoyed the message that was delivered. I think if we walk away with anything, it's going to be the entire ecosystem, our patients, our payers, our providers, all partnering to address the challenge. So thanks so much.